Hi everyone, Vic Gatto here with the Health Storm. Today I have a great guest on, Paul Harkaway. He's a physician who sort of moved his way up through physician leadership, and he ran a very large group that was risk-based ACO for a large health system in Detroit. Great guy, really thoughtful guy about where healthcare should go. We talk about all kinds of aspects of health given COVID and all the changes going on. It's a great show. I hope you watch it. Again, Vic Gatto, have Paul Harkaway on the Health Storm. Okay, welcome everyone to the Health Storm. I'm Vic Gatto. Today I have Paul Harkaway with me. Paul, thanks for doing this.
My pleasure.
So we are at an interesting time with COVID sort of still really a challenge in our healthcare world, and you're a consultant trying to help clients navigate with this. Before we dive into all the details of the storm that we're kind of in the middle of now, talk about your background. You're practicing physician, then you moved up to management. You're at a large health system. Talk about, give your background a little bit.
Yeah, so pulmonary critical care doc, I practiced that for 30 some years. But in the mid to late 90s, I got involved in our local environment with the physicians, with managed care coming down the track, and got actively involved in that. Ended up leading an independent physician association, did managed care contracting, risk-based contracting. We had full risk again back then. And then, as everybody knows, the managed care train derailed. We kept doing the work for a number of different reasons unique to the great state of Michigan. But so I had a managed care experience going way back, and in fact got into my bloodstream. I think in its pure form, it was a better way to care for patients. Then after the Affordable Care Act, I ended up going to a large system to build clinically integrated networks for them in each of the places they had a physical presence, and then subsequently ACOs under the Medicare CMS model. Did that for 8 years, and then moved on and now just doing some consulting, but mainly working with physicians, provider organizations to try to help them understand, what it takes to be able to be successful and where I hope we're going.
Yeah, excellent. So talk to me about your experience with ACOs or with risk-based relationships for providers in different forms. It feels like a tension to me in the sense that we kind of have one foot in that camp, but we still are also doing fee-for-service, and that's a hard thing to balance. But talk about your experience, what worked, what hasn't worked with ACOs or with risk in general.
Yeah, so, I think you hit the nail on the head. One of the biggest challenges, and again, I come from the physician-provider perspective. That's what I am. Two things. First is it's what am I doing now that's so wrong, right? So I don't know many physicians out there that think they're practicing bad medicine and such. And you have to get
to help people, and they're trying to do the best they can.
Yeah, and they view their value when they're in taking care of a patient, not when they're doing other things. So and everything else is a bit of a distraction. But if you work with them enough, you get them to understand that they're part of a very broken system, and they know that, right? 50% burnout rate amongst physicians, they know they're in a broken system, and that there's an opportunity to change all that. So, but as you alluded to, I just want to reemphasize that. One of the struggles that we have is flipping, the 2 foot in 2 canoes phenomenon, right? And being stuck in the middle. It's one of those, I can live where we are, I can live where we're going to be, but this transition may kill me, and we're stuck in the transition. So I think one of the means by which we're going to move forward is trying to have a more substantive move into the risk or managed business, as opposed to split attention, because it's very hard to manage a practice and manage patients and have 2 different mindsets about how you're managing. And I think that's been a barrier. The reimbursement system in general has been a big barrier to making this movement, and the ACO stuff is it's a little bit of an add-on. We'll do a little bit of this stuff over here, it'll be fun, et cetera, et cetera. Well, it wasn't so long ago that there was a study that showed half of the docs that were in ACOs didn't even know they were in one. So So my view is this: I don't consider them a success. I'm sorry to say that. I know there are people, it's kind of glass half empty, half full. I know there's some people that think they've been wildly successful. I don't see it. The savings have been modest at best.
Yeah.
The quality improvement is pedestrian. So, and it's taken too long, right? We've been doing it for 8 years now. How long are we going to keep marching forward with it?
That's how I view it. I mean, I think we learned that aligning incentives can make a difference, but that's fairly obvious, right? Like every middle schooler would tell you that. And then we have not gone far enough that you could really see an impact. And so I agree. I think it has not really been enough. But I want to come back to that because I think that's a whole topic. I want to talk to you about this is called the health storm. The main thesis is that the healthcare industry is being pretty radically disrupted and kind of remade or redesigned over the next 3 to 5 years. The COVID pandemic has really, I think, changed the attention of people. I mean, everyone knew that we needed to do something, but the amount of energy behind it, I think, has been a catalyst for change. Maybe in early ways at first. I mean, I think there's 4 drivers that I was talking about before COVID that I think now are being accelerated. So those are technology, finally coming and driving efficiency. I think certainly telehealth was pushed out because we needed it during COVID. Another one is the rise of the consumer and individuals, patients beginning to try to take more authority, more control in their healthcare. Kind of a fragmentation or a decomposition of the hospital, where it used to be that everything was done in the hospital, to now we're bringing things to the community, to the to the retail center, even to the home, and non-traditional players jumping in. So Walmart getting into healthcare, or Apple jumping in and trying to have a role to play in healthcare. Those things were going on last year, and people have been talking about them coming for a long time. But it seems to me that COVID sort of has brought the storm closer to us. What are your thoughts about that?
Yeah, so I won't say I outright disagree with you, but a couple observations.
Yeah.
And it's okay if you don't invite me back on.
That's okay. No, I want strong opinions.
Okay, so first off, and I'm inherently impatient, and I'm not an incrementalist, right? So we've got a very dysfunctional healthcare system that's not meeting anybody's needs very well, both those who pay for it, those who provide the care, and those who receive the care. And it's been that way for a while. We're increasingly putting ourselves in debt to get healthcare provided, either personally or at a national level. So, how long are we going to take to really take this thing on? And I've heard the 3 to 5 years things now, probably for 25 years.
Yeah.
Starting in the managed care era, right? The Clinton plan, this was going to be it. Managed care, the train's coming down the tracks, you better get on. Within 3 to 5 years, it's all going to be different. And same thing happened when the Affordable Care Act came out and ACO. Same thing happened when MACR came out. When I was at the healthcare system I was working at, I'm sitting there predicting, guys, we got to get, this is all changing, and we've got to get lined up, and, fee for service and use of inpatient is going to go down. Don't be building new hospitals. We're over capacity, all that. It didn't change that much, right? So I hope you're right, because I'm a fire starter with this stuff, but it's amazing how resilient the healthcare system has been to change, despite pretty potent forces moving it the other way, leapfrog, and the employers being upset and all that. So point number 1. Number 2, I want to believe technology is facilitating and helping us. I can tell you my experience with the EHR and pretty much any clinician I know, not a game changer. And if it did change the game, sort of the wrong way, to be honest with you.
Yeah, let me jump in there. There's no question that EHRs were not did not drive efficiency. If anything, they made it worse, right? It was
Made it clearly worse.
more
Much worse.
time and less quality care, less care.
Yeah.
And what I'm pointing to is more the use of telemedicine, or the use of kind of technology to help with diagnostics, or remote patient monitoring. These things are emerging now, and I would argue, and I'm interested in your opinion, that physicians would like to use them, but they need to be paid for them. I mean, if they are answering email for 4 hours for patients and not paid for that, that's 4 hours of time they could be doing something else. And so when we began to reimburse for telemedicine and we got rid of the ridiculous state-by-state regulations and docs could practice and take care of people, of course they'd rather do that efficiently. What are your thoughts about that?
Yeah, no, I agree with that. I think, telemedicine is nothing new, right? So 20 years ago, I'd be seeing patients all day, and then I'd have phone calls coming in all day, and through the day and in the evening, I would call patients up and follow up with them, and it was mainly just me listening to them and knowing them well enough to be able to intercede, right? So that's not necessarily new. What's new is now you can do it and potentially get paid for the time, and hopefully we'll move away and are moving away from this notion where I've got to see you physically, I've got to do certain elements of a history, I've got to do certain elements of a physical exam, and then build up a code to bill you based on that, versus I call you on the phone or have a video chat. And I think in the telemedicine thing, in my opinion, again, it doesn't have to be very expensive. 80% of it I can do with a telephone, and give me FaceTime, and I can do the other 20%. And then, blood pressure is more accurate in your home than it is in my office anyway, right? So yeah, I think technology will aid that, but more importantly is changing the reimbursement models, either to paying for that directly, or now if I'm at risk, it's in my best interest not to have you come in and take up time in my office, and maybe I can downsize my office and don't need as much support staff. So
yeah, and we've seen that beginning in the bundles where orthopedic surgeons are starting to get paid for a whole incident of care, and so then they're incented to sort of streamline processes. But it's to your point earlier, it's not really enough. It's been little experiments. It hasn't been broad-based enough.
I agree. And bundles, the recent wrap on the bundles, it doesn't look like they saved much money. Same thing with ACOs. But in the grand scheme of things, 0.02% savings, hard to get excited about that when we got a $20+ trillion debt we're
accumulating. Right. So I want to come back to a place you started, which is a foot in each canoe, and like we can't commit to either one. Let's say, just hypothetically, you and I could drive policy with CMS. We said we're just going to go 100% at risk, full value-based care. I think that would be wonderful. That's probably the Band-Aid we need to rip off and just go to. And yet there's still a lot of chronic disease in patients that have not been well managed. And so I think what we need to be ready for is an increase in spend for 2, 3, 4 years, because we'd be doing the preventative work, we'd be doing the better ongoing care, but we would still have the acute care kind of because I think it's lagged. What's your feeling about it? Does that make sense, or am I missing a piece that's important there?
It makes sense, but I don't think the additional spend is necessarily all that much when you look at it in aggregate, right? So whatever I would have to make it clear, right? If I'm creating an ACO or a clinically integrated network, and trying to be all in, right? So we're going to do risk contracts. That's all we're going to do is risk contracts, percent of premium type deals, right? Here's heresy for you. It's got to be closed network, right? So if I'm getting paid to take care of all of your needs, then you can't go out, you can't go to see somebody else besides me to take care of you if that person expects to be paid for your care, because I've already been paid to take care of you.
And furthermore, they need to be in your system and play by the rules of your architecture, however that is.
So if you put those elements in place, right, then what am I taking risk for? I'm really think about a primary care physician who's now capitated, and they're at risk, right? That's all the money you're going to get to take care of these X thousand patients, right? Well, what am I at risk for? I'm at risk that I may have to see more patients than I thought I was going to because of something happens to them, right? And that all evens out anyway. So it's really a safe, relatively safe way to take risks, so to speak. If you think about that now from a system standpoint, all my risk is on the margin. So you know what? We had to do 4 more hip replacements this year than we thought we were going to. So I had to absorb the cost of 4 additional, but it's all internal costs, right? It's all part of my system. But what I see going forward, and by the way, the only answer I can see is to have integrated networks, physician-driven, sorry to say it, not controlled, but leading it and influencing it, and willing to take risk for the care they provide, and insisting that it has to stay within network unless the care can't be provided within network, because again, if I'm taking risk for it, you can't just go somewhere else. And then I think with that, the fundamental challenge then is, how do you protect me from pure insurance risk? So my favorite example from the past, but you could imagine with COVID, this being another example, you know, I don't want to take risk for the next pandemic, right? So how do you protect me a little bit? My example from the remote past was we financially were harmed severely because of the way the model was created, because the birth rate went up in the community we were serving. Well, I don't want to be at risk for the birth rate, but any mom and child that needs our care, I'm willing to take risk that we'll deliver that, and we'll deliver that in a quality way. And if for some reason we have to redo something, that's on me.
Yeah, so that sounds like a decent model of a closed integrated network that's full risk. And it would be, I think, a combination of preventative care and more care management. But you think it could be managed inside the costs of the system? Like if there's a few more, I don't know, there's a few more stents or a few more hips or a few more things that's on the margins and it should be manageable.
That's my opinion.
Yeah.
That's it. If you got both your feet in one canoe.
Right.
If you're not, again, particularly for a hospital system, because the early success for an integrated network in ACO is keep people out of the hospital. If I can manage more effectively, and it's a good thing, right? Hospitals are inherently dangerous places. You can only make them so safe. When somebody needs to go there, they should go there, and the hospital should be appropriately reimbursed to care for them. It blows my mind that hospitals bursting at the seam with COVID patients have been losing money hand over fist. No, they're taking care of desperately ill people. They should be able to do that without suffering, but it's part of the perversity of the payment system. So then if a hospital is part of one of the integrated networks, understand we are specifically going to try to reduce the use of inpatient because it's costly and it's dangerous. But the reimbursement model now isn't going to punish you for that, because you're flipped out of this fee-for-service butts and beds mindset, and instead you're in a population health mindset.
Yeah, well,
again, it's got to be quantitatively.
You're in a city like Detroit, and you have an acute care center, but you could then add more and more clinics around the periphery and go further out as you pull down the number of hospital stays per patient or per 1,000 patients. And the overall model would be more profitable, as opposed to where we are today, which you got to figure out how to fill the capacity we have in the hospital, because I'm paying for this building.
You got it. And you try to right size your capacity to what your need is, not anything else.
Yeah. And so is it right for me to say that canoe is the only canoe that has a happy ending? Right? The fee-for-service canoe doesn't end well with the number of boomers that are out there.
So that would be my opinion. Mm-hmm. If you look at it for the collective good, I don't see Plan B, right? I just don't see it. when you're driving waste out, so the estimates are 30% of healthcare is waste. Nobody in healthcare denies it, and there's some actual evidence to support, although it's kind of a funny number. When 30% of what you're doing is wasteful, somebody's going to get hurt when you get rid of that waste, right? But you're transitioning into something, and potentially something that you can feel proud of the fact that it's delivering good care. It's doing it in a cost-effective way, and you're not, again, burdening our children and grandchildren with a debt they're not going to be able to serve us because we've taken too long to figure this out.
Yeah. Yeah. And as we think about how we might get there, it seems to me that you could start with a large payer and then build a physician-based provider network underneath that. Or you could start with a health system or a provider network and then add on the claims administration, risk management aspects. You have to start with either of the core competencies, payer, provider, and then build towards the middle, like a Kaiser or a Geisinger. So there's several smaller systems that have that. It seems to me that coming out of COVID, my next question I wanted to talk through is you sort of made the point. We're relying on these healthcare heroes, first line of defense. They're literally saving lives that we need them to save. And in that work, they are losing market strength and losing financial power. And the payers they're not doing anything wrong, but they're not really saving lives, and they're gaining in strength and power. And I think that's going to be a challenge as we move past the health crisis and move into like the new normal later of how do we rectify this. The Aetna, United, et cetera, Humana, they are going to be in a strong position to continue to sort of build out this future case. And so I don't know what to do about that, but it seems like it's going to be a challenge.
Well, yeah, I'm not thrilled about that, right? So in my experience, limited as it is and limited in scope, the most rewarding is when you have what I would characterize as an enlightened payer, right? And ideally an enlightened employer too, who wants to do something different. And the payer is willing to work with the provider network and develop a new model, right? And understand that there are things that the payers can do that the providers don't have the ability now, and either got to go out and buy it and build it, or let's work in more of a partnership sort of mentality with each other.
Right.
I'll take care of the patients, get out of that, right?
Right.
I don't want my care, if we're going to use care managers, I don't want them at the health plan. I want them as part of the integrated provider network. So you get out of that business, turn that over to me. I'm not going to process claims. I'm not going to do marketing. I'm not necessarily going to do health assessments. You can do that stuff if you want, right? Define roles for each other that don't overlap much, and then go out and do good, right?
Yeah.
And
whether you do that all under the same brand or there are two different platforms, the same material, right? You still need to define the roles and work together.
You got to define the role and work together, trust each other, know that it's hard work, know that you're going to fumble and stumble, and you're going to own it together. And I've had those conversations with health plans. So, but I think healthcare has been an unusual industry in that the insurer has moved so far into the provider side. What other example of insurance works that way? I don't know of any, right? So, yeah. So that to me is the model that has the most success, but you don't see it happening much.
Yeah. Well, I think it's because there hasn't been financial incentives to do that. But if we move to now it's not a big enough percent of claims, but if we get to 10%, 20%, 50%, 80% of all dollars are under a risk-based kind of paradigm, there's going to be partnerships that get aligned to deliver that.
I agree. I hope.
Yeah. Well, I think whether it happens next year or in 20 years, that's the only place it goes, I think. I
agree with you. Again, I lament the fact that it seems like it should happen in 3 to 5 years. And it's, there was group working wanted to flip the switch so that 75% would be in this risk-based, risk for total cost of care by 2020. Not even close, not even close. And that's with specific energy devoted to trying to flip the switch. You got to get a lot of different parties aligned to accomplish that.
Right. I want to talk to you about timing. So we're sort of in the middle. Maybe we're on the beginning of the end of the real public health crisis, depending on how the winter goes. I'm kind of worried about the flu season, but I've been talking about this in a public health world, that there's crisis, recovery, and new normal. First of all, do you think that's the right way to think about how COVID kind of propagates out? And then how would we know when we begin to move into new stages?
Yeah, so one would hope that we'll never have, this will be the last pandemic that, comes that we weren't prepared for and couldn't figure out how to manage more effectively. One would hope that. But I'm not sure I see it as the spark that's going to change healthcare. It's going to change, this is all opinion, right? One of my high school teachers, say what you know, say what you don't know, say what you believe, label them appropriately. This is my belief. I don't know anything. It's going to change the telehealth thing dramatically. People aren't going to want to go back. I didn't need to see you last year. You were perfectly content with doing this, over the phone. Now you say I got to come in for an appointment. I don't want to. I don't want to sit in your waiting room. I don't want to take time off work, right? So I think that switch will flip. Feel pretty strongly about that. But I'm not so sure much else is going to change, to be honest with you, as it relates to the healthcare systems. I hope we do a better job from a public health standpoint and a much more coordinated job around data and everything else. But I'm not sure, without additional significant change in the reimbursement models, as we've talked about, I'm not sure COVID in and of itself is going to change much more than the telehealth phenomenon.
Yeah, so I don't know either. I believe differently, but that's the fun of these shows, right? So like my opinion is that there is going to be there's going to be consolidation in the marketplace because of the financial stress that has been caused by COVID. So that's not really a health.
Not arguing that one. I would argue what the value of consolidation is.
Sorry, I lost that. You would argue with that, or?
I'd argue the value. History would suggest that consolidation in healthcare doesn't necessarily create a new model or create value back to the consumer.
Yeah, and so that's certainly right. So what I'm watching is I think there's going to be a decent percentage of hospitals, especially hospitals, but even doc groups that are struggling because they weren't, who would be ready for this? They weren't ready for this. Their billings have gone down dramatically, and they're really busy, but they don't have the revenues. And I think there's going to be consolidation, but not consolidation in the sort of just get bigger, more from payers or from these new entries. And so, I don't know exactly how to predict it, other than just to say maybe Amazon moves, extends further from PillPack into Walmart is already doing clinics. Do they strike a deal further aligned with some centers of excellence where they're sending all their volume there? They've already begun that stuff. I don't know. I think there might be consolidation that changes the deck chairs and sort of drives more of this combined offering. There may just be more of the same, but my hope is that
I hope you're right.
Catalyst for some positive change.
I hope you're right. I would just, my caution, and it's not a caution for somebody to alter plans, but we don't need more disintegrated care. We need more integrated care, relationship-based. I know you as a patient, I know your family, I know some dynamics about you. And if I'm going to have you get care provided in some other part of the system, I'm going to send you to somebody I know. I know their name. I know something about them. I know their idiosyncrasies. And the important stuff about you, not just your medical history, but about you as a caring human being, is going to transfer as well as you move around with the system. So I worry a little bit that if we aren't careful and we don't continue to focus towards integrating the pieces, if we just develop little niches that can do certain things excellent, they'll be more efficient for sure. I've seen that, and they'll be more successful. But they've got to integrate back with a whole somehow too, and that's a challenge. Did some work recently with a company that got that, and it was marvelous. But a lot of times it was, no, we'll just go do our thing over here off to the side, and we'll really do it well. And it's disruptive and it's cool, but it's not helping with the integration part. Yeah. And that's one of the huge challenges. Completely.
So, I mean, the analogy I would suggest is in financial services that you now would go with one bank, trading platform, insurance products, and they really get to know you, and they have a suite of services that they will bring. It's not as personal as you're describing, but it is under a brand, and there's kind of a brand identity, and they keep track of me, and they keep track of what I have liked to buy in the past, and it makes it easier for the consumer because I can trust that JP Morgan or Bank of America or whatever brand you are aligned with, you sort of get to know very well.
You got it.
And that can deliver a better outcome overall. But yes, it has to be integrated and fairly seamless, or you lose the value.
Yes, it's know you in a deeper way and be able to translate that, and based on a relationship, right? It's a trusting relationship. Yeah. You know, as a pulmonary doc, I would see patients with more than one chronic disease, and if they got their care in different systems, it was virtually impossible to coordinate it. And even if we had a common medical record, all it does is help coordinate some of the medical stuff. Very worthwhile. We don't have a common medical record. Another day, another story about how we slipped on that one. But that's necessary. That's necessary, but not sufficient. Again, if I've got chronic illness, there's a lot of it is relationship driven, which means if you've got heart and lung disease, I need to have a relationship with your cardiologist. Otherwise, we'll just blame each other and have ping pong you back and forth.
Yeah, no question about that. I'm interested in your perspective on kind of standards of care and best practices. I mean, a lot of docs, it's a practice of medicine, right? They build up experience and are using judgment and resist any kind of standardization because there are times when their judgment calls for something different. But I'd argue there's also times when standardization would be beneficial across all of pulmonology or across all of cardiology.
No argument. Yeah, no argument. So it's both horizontal and vertical, right?
Yeah, right. How do we move towards that while sort of respecting the practice of medicine being, a lot of work and a lot of time to build up that expertise and that judgment?
Yeah. So if you think of the words, I'm not a huge fan of CMS's ACO program, but if you think of the words accountable care organization, sounds good. Who's accountable to whom? Well, when I work on ACOs, I say the physicians, the providers are accountable to each other, and they're accountable to the patient they're serving, and they're accountable to whoever's paying the bills, right? That accountability to each other is not part of the history of medicine, right? We're used to functioning as solo individualists, sort of artists in our own right. So that's how you start to get at some of the things you're talking about in my mind, right? Where you've now built this culture of mutual accountability. When I can go, hey, Vic, it's the third time I've had a patient come back from you and fill in the blank, right? The wait was too long, you were rude to them, you put them on some screwy drug I don't understand. Help me understand why you're doing that, Vic, because we've got mutual accountability here and you're making us look bad, right?
Yeah, so that's interesting that you went to a cultural shift as like a
Amen.
precursor for really driving change.
Amen.
That's exactly right. That's what has to happen. If you try to just make the change on the tactical level, it
Doesn't work.
right.
Absolutely doesn't work. And go ahead and invent a system that people can't figure out how to game. You got to win their hearts and minds first, so that they really want to do things differently, and then put the tools in place for them to do it and be successful. So the model is there as far as I'm concerned.
Yeah, right. Okay, talk to me about public health. So fairly clear that we weren't ready for COVID to hit. The U.S. invests, roughly half, maybe a third of other countries, depending on which country you pick. So we're at 4% of the economy or so that we invest in public health. So I mean, like generally anything that's not the treatment of care, and it's less than a lot of other countries. I expect that that'll change once the crisis is over and we move into beginning to recover and figuring out, how do we try to make this better in the future. I think one of the reactions will be to commit more investment, more money to public health. Do you see that as happening, and where does that happen first? So where do you see the impact?
Yeah, so I do. And forget COVID for a second. That's a striking and stark example of our failure from a public health standpoint. And again, let's hope that you and I and many of the providers and patients who have suffered don't suffer in vain, that we are smarter in the future. Because we're going to have another pandemic, right?
Yeah. There'll be a new bug that comes out.
Yeah.
The question is, can we be better prepared 2 years
That's right. And the answer should be yes, we must be. So forgetting that for a second, the parlance that healthcare, and it's becoming a little trendy now, is talking about social determinants of health.
Yeah, I hate that term. I don't.
Yeah, I don't like it either. But here's my read on it. Yes, we need to start identifying other factors with health and that contribute to health, and figure out what we can do about it. Understanding that what we can do is somewhat limited. We can't. It's not a problem to solve. It's a set of challenges to try to manage to some extent, right? You and I can be the brightest people on the planet, and we're not going to solve the obesity epidemic, right? There needs to be a much more thoughtful approach to that, and some resources devoted to that. So absolutely agree. For sure, yes, please, yes. Having said that, as being on the provider side of the world, that's not necessarily the healthcare system. Can we get sick care right? So that if you have a serious illness, you'll get coordinated, integrated, timely care. That's where we should be focusing our energy. But as a society, absolutely, we should be focusing on some of these social public health related issues and investing more in it. It's
I think it's a yes and kind of thing. Like, yes, we need to do more about public health. We need to figure out nutrition, exercise, smoking, all these things that are kind of the building blocks need to be done. But I agree with you that, I don't know, I'm not going to be able to claim the facts, but 30-40% of all healthcare spend is in the last 3 months of life, last 6 months of life. And it's a very small percentage of the population. And so we need to manage those chronic conditions, that really acute care, more effectively, because it's better for the patients, and it's also less money if we don't things up.
You'll have more resources to do some of this stuff around
the
public health issues that you're raising, if we stop wasting so much money when we're not really adding value.
Right. Okay. So the last thing I wanted to touch on is, you've been working on this for several years, 20 years, 30 years. What do you wish you knew at the beginning that you know now?
Yeah. Again, I can't help but have the physician perspective, right? And what I didn't realize, and have come to realize, that we've created a system where it's extremely difficult both based on how folks are trained and everything else, is extremely difficult to get physicians to get more engaged and embrace the need to work and manage with the system and help transition it, because rightly they value themselves when they're caring for patients, and they should. But there's a lot of physician leaders out there, but there aren't nearly enough, and they're not necessarily focusing, in my opinion, again, say what you know, say what you don't know, say what you believe, in my opinion, on the meaningful transitional stuff that needs to take place. That was eye-opening for me, and a major source of frustration, to be honest with you.
That there's not the courage to lead as a physician leader, or is it something different than that?
Yeah, I wouldn't characterize it as courage. I would say there's a number of factors that make it undesirable for physicians to get in leadership roles. And when they do get into them, a lot of times they get pigeonholed in doing some certain degree of work that isn't necessarily leading to this transformational change that we need. When I was going around building CINs and ACOs, I started with trying to find docs that could lead them. They were almost always, I had to get them out of the bushes, right? It wasn't ones that were in traditional leadership necessarily. And they were always reluctant. No, I just want to take care of patients, right?
Yeah.
Well, I think, I have harsh words for it. I think as a profession, we kind of abrogated our responsibility for the system part of this. And you can't just hide behind, I'm doing everything I can for your patient, if I'm not doing something about the system that the patients get trapped in.
Right. Yeah. I mean, I know the building's on fire, but I'm just going to focus here in my kitchen and make dinner.
Yeah.
Okay, you're a great surgeon. You're doing a great job in this small niche, but the building's on fire, and so we need you to help overall. Yeah. If you had known that 30 years ago, what could you have done differently? Is it a cultural thing?
It's all culture, in my opinion.
Right.
It's all relates back to culture. I don't know that I could have done anything different other than accept more than, and I still haven't, accept the fact that this is hard work, and you got to be persistent and patient. And if you're looking, despite the fact that you see things that are borderline egregious, if you're thinking they're going to change tomorrow just because you called it out, they're not. And so how do you keep at it and keep it moving forward, and build some momentum behind it?
Yeah. Yeah. It's interesting that, so I invest, of course, in new healthcare things. And I've been doing it for almost 20 years. The biggest mistake, it took me probably 10 years to learn, is how slow things are. Like I'll see something that needs to be fixed and find a solution, and you might be 8 years too early. Like the industry, the market, the incentive alignment, patients, no one's ready to do it yet. And then there's not reimbursement, there's regulatory barriers, and it's just a hard and slow process. So it's a timing thing. I mean, market timing is the thing on investment that makes or breaks almost every investment.
Yeah.
That's related to what you're, at least it reminded me from what you're saying, that just because you see a egregious need to fix something is not the same as saying it will get fixed.
And that's counterintuitive for a doc, right? We're going right. ICU doc.
I can see this. Let's.
I'm taking it out. Yeah, let's get this thing scheduled. I'm going to take it out. It's going to be gone. We're going to move on. Right. It's very different. Takes a very different mindset, and extremely frustrating for physicians.
Yeah. Okay. So I don't want to end on that. Talk to me about, how do you keep up with, there's a lot of things changing in healthcare. For the audience, is there a particular thing you read, or how do you keep up with these topics out there?
Well, A, virtually impossible. B, so much misinformation out there now. Again, I think that's one of the challenges of our age, right? How do you separate the reality from the conspiracy theories and such? But I would say it's pretty random what I'm looking at, and what I mainly try to do is stay close to where go to Gemba, right? Stay close to where the care is. So my source of insight is usually a practicing doc on a Tuesday afternoon talking to them in their office about what's going on and what's happening to them.
Yeah.
So it's very local, but I still think healthcare is a very local phenomenon. There are a lot of things you can coordinate and do a much better job from an efficiency standpoint, but when you boil it down, it's relationships based, it's local, it's affiliated with the community you live in and the demographics of people that you deal with. So I learned the most talking to a doc who just, came out of their office to talk to me for 10 minutes.
Yeah, excellent. Well, Paul, thanks for talking to me with this. It's an exciting time and a little bit of a chaotic time, but I appreciate you sort of helping me make sense of it or try to make sense of it.
My pleasure. Best of luck.
Yeah. All right. Thanks. I appreciate it.